Yes, the first course is about the pathogenosis and the pathophysiology of occupational asthma. And also in the middle, I put also etiology and the different causes. I have no conflict of interest for all this talk about occupational asthma. So this is the usual definition about, yeah, I do that. Oh yeah, good. Yeah. Yes, you have the work-related asthma. In the work-related asthma, you have the occupational asthma and you have the work-aggravated asthma. In occupational asthma is people who developed asthma for the first time when they're at work. Work-aggravated asthma are the people who are already asthmatic and they have their asthma which is increased because of the work. For occupational asthma, occupational asthma, you have the immunological and the non-immunological as occupational asthma. For immunological asthma, you have the mechanism, they are the IgE mediated with high molecular weight agent and low molecular weight agent. We'll see after what is a high molecular weight or low molecular weight. In the immunological occupational asthma, you have the latency period. That means that the patient is working. There is a latency period between the beginning of the work and the development of occupational asthma. And also, you can observational assessment of individual, you can perform specific inhalation challenge to prove the role of the cause in the occupational asthma. In non-immunological asthma, you have, it could be an acute toxic injury, that's the RADS. That means the patient is exposed to a pollutant and then 24 hours after, he developed an asthma, an occupational asthma. So there is no latency period. There is no latency period. It's sudden and no latency period. And of course, in this case, it's very rare that we perform a specific inhalation challenge. After, you have the work-aggravated asthma. The mechanisms are not very well known. It's work-related asthma symptoms and no specific test, but you'll see that specific inhalation challenge for these patients are very important because if it is a negative specific inhalation challenge, it could be approved to be a work-aggravated asthma. This is the same scheme, but here it's different. It's the irritant-related asthma. Again, it's here. We are here. We are here. Irritant asthma, and then this is the irritant-related asthma. In the irritant-related asthma, you have the acute onset that I told you, a very high, single high-level exposure, no latency period, and it's very clear it's an acute and an irritant-related asthma. But also you have some patients, who developed multiple high-level exposures with a latency period, several exposures. And also it's a probable irritant-related asthma. And also you have repeated chronic exposure to low dose to moderate. And this is a possible irritant-induced asthma. It's the position paper with Olivier Van der Plas, all the European people who are in charge, who are involved in occupational asthma. We gathered all together and we try to define this notion of irritant-induced asthma. But now you know that for asthma, we are talking more and more about phenotypes. And the true phenotype, it's an endotype, it's a unifying and consistent natural history. That means for one disease, you have one kind of phenotype. He has a consistent natural history, a consistent clinical and physiological characteristics, the same mechanism, underlying a pathobiology with a biomarker and predictable response to general and specific therapy. For example, I will talk about T2 asthma, non-T2, and because it's we are trying now it has been now more than 20 years, we have been developed this concept of T2 and non-T2 occupational asthma or asthma, and it is why the question is where to put the occupational asthma. Here, this is an old slide, and you have the T2 asthma with the allergic asthma. You have also the eosinophilic asthma, and also you have the non-T2. For T2 asthma, we know a lot of things, and there are more and more treatments. For non-T2 asthma, there are not a lot of treatment. But the question is for occupational asthma, because we are dealing with high molecular weight and high molecular weight with specific IG against this agent, are they responsible for a T2 mechanism or are they responsible for a non-T2 mechanism? And one of the path of all the slides that I'm going to show to you, this is the idea, is try to define as much as we can the pathophysiology of asthma. Here you have the classical definition now of asthma. You have the epithelium. The epithelium, 20 years ago, nobody took care about epithelium because epithelium was just a barrier. But right now we know that epithelium is very important because epithelium can produce chemokines and particularly alarmins like TSLP or IL-33, which have an influence on the dendritic cells, and they have an influence also on the TH and the TH0. If you look at that, you have the T2, you have the T2, you have the T2 pathway, you have the TH2 with IL-4, and IL-4 and 13, they induce for the B cells the production of specific IG. The specific IG, they go to the mast cells, and the mast cells is responsible for the answer, for the allergic answer, for rhinitis or for asthma. Also, they can produce IL-5, and IL-5 stimulate the eosinophils, and the eosinophils, they produce basic proteins, which are very dangerous for the mucosa, the bronchial mucosa. The other part is the TH0 could produce IL-17, and IL-17 stimulates the neutrophils, and the neutrophils have also an action on the bronchial epithelium. So you have two pathways. The T2 pathway, which is very well known, allergic and eosinophilic, and the non-T2 pathway. And the very important is the epithelium. So the IgE-dependent mechanism, they are inhalation of sensitizer, which are specific of the occupational environment. They are high molecular weight agents, and they are low molecular weight agents. Though the high molecular weight agents, we have specific IgE against them, so we know that they are TH2, and they are also low molecular weight. And for though we don't know what is the real mechanism, is it IgE or not? Well, the weight-rated asthma for the proofs for the T2 mechanism, you have an increase of eosinophil at work and off work. I will show you that. An increase of eosinophil after a specific inhalation challenge, an increase of FeNO after a specific inhalation challenge, and specific IgE to an allergen. The increase of FeNO, you know that FeNO is a marker of eosinophilic inflammation. This is just to show you the eosinophils. Sorry. Yep. The eosinophils. This is the control group with the white circle. There is no effect when they are exposed, when they are at work, no increase of eosinophils. And look at that. When they're at work, there is an increase of eosinophil, of work, a decrease of eosinophils. And ECP is a marker of activity of the eosinophil, because one thinks it's the increase of the number of eosinophils. Another much more important is the increase of activated eosinophils. And if you look at that, you can see that here for the control, no increase of ECP in the blood, and at work, there is an increase, of work, there is a decrease. It's exactly the same for allergic asthma. For example, if you are allergic to birch pollen, during the birch season, you have an increase of your ECP, but not all. You can see here that not all patients have an increase. There is 2/3 of the allergic patients who have an increase of the activated eosinophils. And this is very important to understand why there are biotherapy works or not, why desensitization works or not. About the non-IgE dependent mechanism, the things we don't know, it's the black box. And I will show you that now we know better about the black box. And look at that. This is the IgE mediated, because it's a study that we perform with Florence Liotier in Strasbourg with people working with rats, and we look at all these guys. They have asthma or rhinitis or conjunctivitis. And all these people, they have, among these people, only 50% of them have specific IgE to rat. They have symptoms, they have conjunctivitis, they have rhinitis, they have asthma, so an IgE-related disease, but in fact, only 50%. And you have exactly the same with wheat flour, because I think allergen could be, of course, the allergen, but could be also irritant. And this is my first question about that. At this time, I was thinking about that. Okay, it's a high molecular weight agent. Okay, maybe we could have IgE-specific IgE mechanism, but maybe there is something other. So irritant-induced asthma, so that there is no acute, it's the second category of asthmatics. The question is, all the agents who are responsible for irritant-induced asthma, meaning is there a sensitization or is there an irritation? Irritant, are non-corrosive substances that cause a temporary inflammation on direct contact. What does it mean really? What it is an irritant? We can think that there are epithelium damages, stimulation, and stimulation of the innate immunity or the adaptive immunity, because of the alarmin, because of the TSLP or IL-33. And irritant-induced asthma also can induce epithelial cell release of inflammatory mediators, activation of the neurogenic inflammation, also inducing reflex bronchospasm. So all you can understand that there is a mixture. Of course, there is the specific IgE and very classical pathway, but also you can have also more mechanism, like the innate inflammation, like the neurogenic inflammation. About sensitization, what are the clues? For example, with irritant-induced asthma, with the cleaning substances, we perform studies with ashok in our group, and we perform bronchial challenge test, and we demonstrate that we obtain a bronchospasm, a drop in FEV1, using quaternary ammonium in nurses. That was the first time. Also, you can sensitize with quaternary ammonium. Are they sensitive or irritant? You can induce also contact dermatitis. And also, more interesting, that it could have an adjuvant effect. It could have a T2 effect. For example, you have pig farmers. It's in the Danish farmers, 124. And those who used quaternary ammonium, they have they have more atopy. You look at the odds ratio is 7.4. So just using quaternary ammonium increase the risk of atopy. And also the adjuvant effect could increase the permeability of the airway epithelium. It's exactly that we found also with formaldehyde. And also, still with quaternary ammonium, when you perform a specific inhalation challenge, you can see that you increase the non-specific hyperresponsiveness after the challenge, but you increase the eosinophils. So you are performing an exposure with some substance which is known not to be Th2, which is known to be not an allergen. And you produce a T2 response. So it seems paradoxical. Also, you can have an antioxidant effect. And this is big studies. There are Spanish workers. There are also some studies in Spain where we found that oxidative injury not limited to acute and direct effect. There are also studies in France with more than 700 adults, and they increased the levels of oxidative products. And also genetics, very large cohort studies, and which demonstrated that with more than 2,000 adults, they are exposed to different agents. And the most important, all the genes that we found for these patients are related to low molecular weight agent. So I'm sorry, maybe it could seem confusing because we all have studied high molecular weight, low molecular weight, immunological occupational asthma, and then irritant occupational asthma. It is just to show to you that things are a little bit more difficult, more complicated to understand. So the neurogenic inflammation, also you have some studies demonstrating that also there is an effect of sensory neuron innervation airways. And using with the transient receptor potential expressed in neuron and cells of the lung, and there is an activation. And this also, the neurogenic inflammation could be stimulated by the innate and the adaptive immunity. And to demonstrate the effect of the neurogenic inflammation, this very old study. It was Peter Barnes' study. Peter Barnes was a very famous pulmonologist in London. And what did they found? They found that they performed in 9 patients with atopic, with mild asthma, and the patient pre-inhaled ipratropium bromide or saline, and also chromoglycate, sodium chromoglycate. And they perform a bronchial change test using quaternary ammonium. And this is the results. If here you have the saline, when they nailed the saline, you have a drop in FEV1 very quickly. And when they used using the benzalkonium chloride, which is a very famous quaternary ammonium, and when they pre-treat with chromoglycate or with they pre-treat with ipratropium bromide, they stopped the drop in FEV1. But they stopped, look at the drop in FEV1 within 2 minutes with the benzalkonium chloride, with the quaternary ammonium. The drop occurred very, it was very short. The time to obtain the drop in FEV1 was very short, which could eliminate a role of IG specific mechanism or irritant mechanism. It seems that it's mostly neurogenic inflammation. So it was a little bit difficult. Sorry about that. So I wanted just to that you understand that there are several mechanisms which could induce occupational asthma. And right now, we don't know very well what is the part for one agent versus another. But we try to improve our knowledge. And you have also the biocides. Yes, the health worker, it's very important. The chlorine, the quaternary ammonium, I will be back because it's now it's the first causes in Europe. Colophany also, the D-isocyanate, it was very, very frequent in Western Europe. Now it's less and less because because there were factories for cars, there was factories different. You have the spray painters, the makes the processor of polyurethane, but in fact now they are mostly in the eastern part of Europe. Also the methyl, the chromium, the cobalt, nickel, zinc, and also the persulfate. Yes, it's for the hairdresser. It's the major cause of occupational asthma is the persulfate, and because yes, it's induced skin lesions, but also rhinitis and asthma. Platinum also, and some wood dust. Iroko, obeche, sapele. Usually, it's mostly African trees, but I'm sure you can also have occupational asthma with other wood. Well, this is the incidence. The incidence, for example, in Europe, it's 250 or 300 cases per million of workers per year. It's a high cause of asthma. It is why it is very important when you have an asthmatic patient in front of you, you need to ask him or ask her, what is your job? Because it's from 10 to 15% of all asthmatic. In France, the incidence is 10 cases per million of workers per year, but you'll see that it depends of the way that you perform the study. For example, in Finland, it depends also the way how the people are paid, the remuneration when you declare an occupational asthma. For example, in Finland, they are the champion. It's 174. In Sweden, it's 80. But if you go for France, the usual figure is 24. But in Alsace, Alsace is the region from Strasbourg. We did a study a little bit. We pushed the occupational doctors and all the pulmonologists to declare all the occupational asthma, and we obtained 126 for the incidence. In Catalonia, see 159. They were very good also. The same way they push all the doctors to obtain results. This is just to show you, for example, this is in France from 2008 to 2011. It was in 3 regions in France, Alsace, Paris, and Le Doubs, and it's a small part south to Alsace. And just to show you what the first, according to the social category, workers are those who are the most, they have the most occupational asthma. The farmers also. And also, if you look at the manufacturer, the food producer, the beverage, also they have a high incidence. And if we look at the cause in France, it's flour, so bakers first, and then wood. Latex now is very low. You remember latex was very high. When I was a resident, latex was one of the major causes of occupational asthma. I remember when I was giving courses to medical students, I say, yes, you must be careful because you can have occupational asthma. Now it's almost nothing. It's because of prevention. So it's possible to decrease an occupational asthma just with prevention. Also, you have molds, grains, and animal-related. Also, it's important, as I told you, with the veterinarian and all the people, because I don't know in Colombia, but in France and Western Europe, pet animals are so important. There are more and more people working with the animal. About the chemical, the first of all are quaternary ammonium compounds, 15%. So cleaning is now the first cause of occupational asthma in Western Europe. Parasulfate is just after, so the hairdresser. Isocyanate now is very low, 20 years before it was 25%. Now it's 8%. And you have also chloramine. Look at that. It's mostly products for cleaning. So floor first, and that's I already told you. Just 2 slides about occupational COPD, because maybe you could be interested in that. 31% of COPD never smokers. So the prevalence, it is calculated that the prevalence of occupational COPD is 15%, and the cause are dust, gas, vapors. And there are the professions are dairy farmers, the grain workers, the cotton workers, bricklayers, and the welders. Remember, when you are talking, usually the welder, they have very often obstruction, bronchi obstruction, and the people think it could be asthma, but also it could be occupational COPD. So now, because of all this confusion, I work with Olivier van den Plas, who is in Belgium, and we created a cohort, a European cohort, which is named EFOCAS, European Network of Phenotyping of Occupational Asthma, with different centers in Europe, in Finland, in Poland, in Spain, in Barcelona, in Madrid, in Italy, in UK, in France, and all these centers, they could perform specific inhalation challenge. So we were very clear about the definition of our patient. We're clear about it's clearly an occupational asthma. And we have more than 1,000 patients. And our first idea was, is it this definition, high molecular weight versus low molecular weight, is it still valid? It was defined by Malo now 30 years ago. It worked very well when it was created, but now we need to carry on because of the phenotype. And just to show you what were the literature at this time about that, there was the low molecular weight agents. There was the publication from Quebec. The low molecular weight agent, they are more frequent late or dual reaction performing when you perform a specific inhalation challenge, and you have an increase of methacholine bronchial methacholine challenge test. Also another study from Italy, low molecular weight agent, longer work at exposure before the onset of asthma, less eosinophilia, higher prevalence of late reaction. And then another study from Belgium, the high molecular weight agent, after challenge, post-specific inhalation challenge, you have an increase of FeNO and with a threshold of 17.5 ppb. So it's the data that we had at this time. So we perform a study with our cohort. And of course, which was interesting that we had more patients, 400 and 600, high molecular weight agent, low molecular weight agent. And we look at the age, there was a difference. The high molecular weight agents, they were younger, they were more atopic, but look at that, 58% versus 44%. Though that's more in the low molecular weight agent, which is so-called non-T2, mostly more irritant and so on and so forth, 44% of them were atopic. Then we'll look at the smoking, not very interesting, but for a high molecular weight agent, rhinitis, conjunctivitis, urticaria. This is related with the atopic status. The duration of exposure before with the high molecular weight was longer with the high molecular weight versus the low. And the duration of symptoms while exposed at work was higher with the high molecular weight. Here, I think it's the most important. It's just to look to have that the inhaled corticosteroid, but it's not very 61% versus 70%. It was not so important. And if you look also at that, it's the FEV1. The FEV1, the 23% of them, they have a more severe bronchial obstruction. So in summary, you have more rhinitis in high molecular weight agent, more conjunctivitis, more early asthmatic reaction, more airway obstruction, and more atopy. In contrast, more exacerbation with the low molecular weight agent, late asthmatic response, daily sputum, and chest tightness at work. And this is the last point, is very interesting. And Gianna will talk about that, because I think we discovered also the effect of the laryngeal dysfunction, and you will see after. Also, we look at the blood eosinophils, and the T2 versus non-T2. And here you have 49% versus 34%. And it was different. Of course, the high molecular weight agent, they have more eosinophils, and more also the increase of the FeNO after the specific inhalation challenge was more important. Okay, there was a difference. But we look at the acrylate. It's, oh yes, you can see that. Is the Suaja Abuelo. She's from Finland, and she used our cohort, and she performed a study with the acrylate. The acrylate are known; they are chemicals, and they are non-allergen. They are not allergen. They are non-T2. And if you look, this is the acrylate, the cyanoacrylate, the methacrylate, and they are, they use for lutein for the glue, for the nail, for the eyelashes, also for the floor. So they are very widespread. You can find acrylate everywhere. 55 patients, they have occupational asthma because of acrylate, and we compare them to the 418 work asthma caused by low molecular weight agent. And in fact, the acrylate, they have more rhinitis, more increase of FeNO. So their behavior was mostly more T2 rather than non-T2. So they are considered low molecular weight agent, but they react as high molecular weight agent. So it was the beginning. That's the things that we were guessing, that things are not so evident. And here is the same. I have already shown to you this slide, but also with the cleaning agents, those who have a positive specific inhalation challenge, they have a T2 behavior because they have an increase of eosinophils from 0.02 to 0.12, and they have an increase of non-specific hyperresponsiveness. That means that with acrylate, with cleaning agents, you have mostly a T2 behavior instead of T1 or non-T2. Now, if I try to gather, when you have a T2 neutrophilic asthma, this is in non-occupational asthma. People are older, they are non-atopic, in the absence of response to corticosteroid. In contrast, upper asthma T2 with a high T2, stronger hyperreactivity, bronchial obstruction more important, and they respond to inhaled corticosteroid. So the idea, it was another study, was to relate these 3 points. What is the relation between the agent type and the exposure, the bronchial inflammation, and the clinical characteristic? So we know that, I told you, that high molecular weight agent, they are wood flour, latex, animal enzyme, low molecular weight, isocyanate, persulfate, methyl acrylate. We know that there is an IgE-mediated mechanism, but sometimes it's not so true. And here we don't know very well the mechanism. We know that for this patient, we have chronic sputum, exacerbation-led reaction for the specific inhalation, and for the high molecular weight, rhinitis, atopy, immediate reaction, increase of FeNO. So again, we go with our cohort, and we perform a study to try to define what is T2 and non-T2 in occupational asthma, making the relation between the agent the symptoms and the mechanism. So we had 1,500 patients, but in fact, at the end, we have only 372 because in different centers, they don't perform induced sputum, and we define a T2 or a eosinophilic, not T2, sorry, eosinophilic reaction or neutrophilic reaction by eosinophilia increase of more than 3% in the induced sputum, and neutrophilia increase of 70%, not increase, 70% of neutrophilia in the sputum. Before performing the specific inhalation challenge, you have, this is the repartition, the distribution of the patients. Eosinophilics was a little bit 1/3. You have also the mixed granulocytic, that means they have eosinophilia and neutrophilia. They have the neutrophilic patients, and you have the post-granulocytic, that means the patient who have no cells in their induced sputum. And then after you perform a specific inhalation challenge, and you have an increase of the eosinophilic. So the people, like if when you perform a specific inhalation challenge, you increase your T2 reaction. And those who have a positive specific inhalation challenge, they are more T2. But also you have some of them are still neutrophilic because the threshold for neutrophilic was pretty high that we used. So 70% of our patients has had an eosinophilic pattern with a specific inhalation challenge. There is no difference in age, obesity, smoking habits, atopy. The majority of the majority of the agents were high molecular weight, 60% versus 44. They have more rhinitis, and they were more severe, higher treatment level, and more specific, more bronchial hypersensitivity. Those were neutrophilic, only 11%, which is exactly the same ratio when you are dealing with severe asthma, non-occupational, because also we are very interested in severe asthma. It's exactly that. You have 75% who are eosinophilic, 11% who are neutrophilic. No difference, age, smoking habits, atopy, low level of education, and this is important, and more dysphonia. And I would like that you, after this course, you think about the larynx, because, and Diana is going to talk about that, because it's very, very important about the diagnosis in asthma or occupational asthma or in non-occupational asthma. Larynx is very important in asthmatic patients. And severity, it's a lower treatment level. Now, if you look according to the different agents, acrylate, 100% of eosinophilic, so 100% so-called T2. Wheat flour, 75%, but still 9% we are neutrophilic, which this, remember when I was talking about the rats, there were 50%, only 50% who have specific IG against the rats. And I said, maybe at this time I was thinking, maybe it's just irritation. But look at that. It was the same wheat flour. The Dutch people found also the same results as we found for the rats. And we can explain that because there are some patients, even if they are exposed to wheat, it's not an obligation to have a specific IgE and T2. It could be neutrophilic reaction. Also isocyanate, it's a low molecular weight, 15%, 50%, they are eosinophilic. And look at quaternary ammonium, 100% eosinophilic. And also persulfate, 61% eosinophilic. So the same agent could induce a neutrophilic reaction or an eosinophilic reaction. Now about the severity of occupational asthma, because severity also, it's a real problem. It's another phenotype. The severity in the literature was related to smoking, and there's a publication from Italy. Also, it was related to the duration of symptoms at the diagnosis. If the patient stay longer and longer, too long at work. And also the asthma severity was at this time, according to this study, was related with the FEV1, the drop in the FEV1 less than 70%, and the PD20 methacholine. Also, there is a study from Spain, low molecular weight agents. It's related to severity and the associated occupational and rhinitis also in Spain and Italy. And they found that the patients who have rhinitis, they are more severe occupational asthma. Again, our cohort with all the people, and we published that, yeah, and this more than 900 patients. And there we studied both. Those who are at work when we perform the specific inhalation challenge. Sorry, it's in French, I missed that. And those who were not at work when we perform the specific inhalation challenge. And we look at the severity, and we look at the spirometry, non-specific hyperresponsiveness. And also we look at the retrospective data about severity and control when those were not at work when they were exposed, how did they were, and how did they are when they were, when we performed the study and perform the specific inhalation challenge. So the definition, you know the definition about the severe asthma, you know everything, the high doses, at least one of the criteria, the SABA one a day, at least 2 severe exacerbations in the last 12 months, and FEV1 less than 50%. Oh, sorry, yeah, it's our definition in our study, but look at our prevalence. The prevalence that we found at work for those were at 16%. Those were excluded for the work, 11%. In the general asthmatic population, it's 4%. So there are more severe asthmatic patients in occupational asthma than in the general population. Oops. They are the variable. What are the determinants? The determinant for severe asthma is the duration at work. The exposure, the persistent exposure versus the reduction. The low level for educational, less than 6 years for educational training. Asthma before 12 years. And chronic sputum and dysphonia also. This is the determinant. And after, if you look at the variables which are related to the exposure, the exposure at work, the socio-demographic factors, and the clinical characteristics. This is the factor related to the exposure. Low molecular weight was a risk factor, and also for the GINA, for GINA 4 and 2-5, the duration, the symptoms at work, and the exposure, the persistent exposure. So again, persistent exposure, duration of exposure, even when you have symptoms, it's a risk factor for severity in occupational asthma. For demographic, it's interesting because it's the level of education also, and for the characteristic clinics, it's the chronic sputum, sinusitis, and dysphonia. So again, severity, if we try to summarize severity and control, to have the severe GINA 4 and 5 at work and out of work. For those who are at work when we perform the specific inhalation challenge, for those who are not at work when we perform the specific inhalation challenge, there's no difference. But in the use of short-acting beta-2 agonists, there was a significant difference. So that means it's good when you are a severe asthmatic to be out of work because there is a difference. Exacerbation, there is a difference. And the definition of severe asthma, there's a difference. So it's clear, the one message is when you are when you consider that your patient is severe asthmatic, he has to be removed as soon as possible. And you'll see when I'm going to talk about treatment, it's not so obvious. We have to be careful and to be practical. But for those patients, these patients are particularly at risk. And those for the patient were outside work when we performed the specific inhalation challenge. the marker of severity are completely the same as the marker of severity for severe asthma. Obese, the low level of training, and also chronic bronchitis. So now I'm finished with the occupational asthma.